Good morning, everyone. Thanks, Celia, for the non-introduction. I'm Joost Breeksema. I'm the director of the Open Foundation in the Netherlands. We organize conferences as well, and I'm also researcher at the University Center of Psychiatry at the University Medical Center in Groningen, where I do qualitative research and mostly interview patients about their experiences with psilocybin, MDMA, and ketamine for treatment of severe treatment-resistant mental disorders. And what I'll be talking about today is some of the results of my qualitative research into patients treated with oral esketamine for depression. So before I'll go into the results, I'll share a little bit about the study context, the treatment context. So the treatment, this is really hard to read, but it's oral esketamine. It's liquid esketamine, which is generic in the Netherlands, so it's very cheap. It's administered to patients with treatment-resistant depression, which in the Netherlands, most patients that I've interviewed have been depressed for a very long time. They've tried multiple treatments, the majority of them including ECT, so they're properly considered treatment-resistant. Some cases, treatment-resistant means you have had failed two adequate antidepressant trials, but these are mostly people who are very treatment-resistant. So the treatment, it's an off-label treatment, consists of an initial 6 weeks in which people get esketamine twice in escalating doses. So starting at 0.5 milligrams per kilogram and then titrating up according to initially at least according to the assessment of the psychiatrist. And this is, I think this is important to contextualize. It's administered purely as a pharmacological treatment. So there's no psychotherapy. There are some education about the effects of ketamine, but that's about it. And people who responded well to the initial 6 weeks of ketamine, they were, after careful deliberation with patients and therapists, considered for continued use at home of ketamine. So this is take-home ketamine, which people need to pick up at the pharmacy each 2 weeks. And so I've interviewed some patients who've progressed from the initial trial phase to the at-home use as well. So just to contextualize, I was talking to Shayla last night, and she showed me some of the pictures of the ketamine clinics, and I should have included a picture here just to juxtapose what our treatment setting looks like, which is really bare bones. This is a treatment room at the university where I work. There are 3 chairs, so in some cases people get ketamine at the same time, 3 people at the same time. This is the university clinic in The Hague, which is an inpatient clinic. So treatment is provided as either inpatient or outpatient, depending on whether patients are hospitalized. But it's very minimal. This is the setting where people are hospitalized. This is their own room. So that's where they get the ketamine. So just a little bit of context on my study. So I was really basically interested in understanding how patients experience this treatment, what they experience, how they experience the treatment, how they experience the treatment context. And so I've interviewed 17 patients, average 49 years old, the majority women. And yeah, as I said, on average, they have failed at least 9 different types of antidepressants or other types of treatments, including psychotherapies, including, in some cases, transcranial magnetic stimulation, deep brain stimulation, elective convulsive therapies. So these are really all end-of-the-line treatments. So what I've done is I made an interview guide. I interviewed patients in depth, the majority of which was done via video conferencing software, so Microsoft Teams or otherwise, because this was all in the middle of the pandemic. Travel was impossible, with some exceptions. And I must say, I found that it was usually quite possible to establish rapport with patients to really get a sense of how they had experienced to what they had experienced, but obviously it's preferable to do face-to-face interviews. Although I did not notice any meaningful differences there. And I used an interpretative phenomenological analysis, which is a horrible term, IPA for short, which is really about understanding patients' own experiences in their own right first, understanding what they say, what they mean, how they interpret their experiences individually before comparing them as a whole, and then seeing what themes emerge, how they compare and contrast with each other, what the similarities, the differences are. So that's the context. I'll tell you a little bit about what I found and what I think that means, and the major themes that came out of my research. So very importantly, preparation is this was something that that most people said was very lacking, especially because they were educated about the effects, but they didn't really understand what the education referred to. So they were ill prepared for the content of the experiences. They were ill prepared for the timing when they might have any effects, and saying that people have that you can expect to have dissociative effects doesn't mean much to patients unless you explain it, as well as the intensity. And I can provide a little anecdote here. This is something that I did after I conducted all my interviews. There was a study running at the university hospital close to where I live, and I decided to participate. This was a pharmacological magnetic resonance study. So they used ketamine as a tool to study dynamic changes in the brain, and they used esketamine. So I decided to participate. This was a randomized trial in which they used IV esketamine. I got a placebo, a low dose, and a medium dose, or well, medium. And I had the same experience as patients because they prepared me. They said, okay, you're going to receive ketamine. You might feel a little dizzy. You might feel a little disoriented, a little dissociated. And this is in an MRI scanner. So when I got the high dose in the MRI scanner, I had no idea what I was, where I was, what I was, that I had participated in a study. And I'm not inexperienced, but I realized this is the same. This is the same experience that many of the patients that participated in this study had. They were ill prepared for the experience. They had no support. They had no real understanding. Nurses there to help them to talk through their experiences afterwards. I was isolated in a kind of tomb, so that was a little different for me also. But also when I emerged, I thought it was important to inform people that this is a very, very intense experience that they're giving to people, and their response was, yeah, I understand. Yes. No, you do not understand. To the point that some of my colleagues that I work with thought this was really unethical to do to people, and the researchers that I spoke to said that they had high dropout rates, which is unsurprising, I think. But just to share some of the quotes, I can't read it from there, so I'll read it from here. Um, they said, well, usually we build up slowly, and the first time you won't notice anything, a little lightheaded or something, but yeah, within half an hour, there I was lying, tripping. And I avoid typical terminology associated with psychedelics. So tripping, that's something that came out of these patients. And most of these people were psychedelic naive. They were not drug users. They were regular garden variety depressed patients. And the second person said something similar. The first time I got such a small cup to drink, and I thought I would only notice something after 6 sessions. And within 5 minutes, everything started spinning and tingling and getting weird. So I was very shocked. I hadn't expected that at all. I was sitting there by myself because the nurses had left me alone. It's sometimes really shocking what patients told me. And it's also this. There was a confusion here because what the therapist had meant that you can expect an effect on your mood after week 3, more or less. But she had interpreted it as you can expect to have some psychoactive effects after the 3rd week, but that's obviously not the case. Even in the first dose at the 0.5 milligram per kilograms, and this is oral esketamine, so it's not comparable to IV. Equivalency is like about 15 to 20%. People still had experiences, and this was related obviously to the fact that they had not expected this. And related to this is the fact that all of my colleagues, when I started this study, and some of them still do, and I still correct them, refer to the subjective effects induced by ketamine or the psychoactive effects as side effects. And that obviously creates a frame of interpretation around what they experience and the potential usefulness or or how welcoming those effects are. And this patient explains it very clearly. We were told very clearly beforehand by the nurses, everything you experience on the intake day, those are side effects. That the 10th strip you experience is just a side effect. And this other participant said, I thought it was a little weird that they say it's a side effect, because in my opinion, it's not a side effect, but just the action of ketamine. And for some people, they related the trip, the subjective experience, to the therapeutic outcomes as well. So they thought it was a necessary effect. But because it was framed as a side effect, even when what I interpreted as therapeutically potentially very useful and meaningful, people discarded it because they thought it was a side effect and it was not necessary for improvement on their moods. And just a little bit about the phenomenology of ketamine. I think most of this is ties in with the literature, what we already know about the effects of ketamine. But I discerned a couple of different categories. Importantly, perceptual effects, mostly visual, auditory, and especially proprioceptive, so how people feel and experience their own body. Um, so this is also important to realize in the context of getting ketamine treatment in the same room with other patients. So if sensory experiences are intensified, that suddenly becomes really disturbing. And this was a person at the inpatient clinic who said a ticking heater, something outside, someone outside mowing the lawn, that hum becomes gigantic, really overwhelms everything. And this is, I think, a typical ketamine proprioceptive effect. I felt like lying on a huge air mattress, which was deflated at certain places, so that I was sucked into one of those holes that went empty when I was lying there. Um, a really interesting one, I rephrased it detachment after calling it dissociation, because I think this is what most people refer to when they talk about the dissociative effect of ketamine. But people report becoming detached from their selves, from their physical selves, but also from the idea of their selves, from external reality, but also interestingly from their emotions. Um, and this person, participant 11, said it's a physical experience, and indeed thoughts pass by, and the feeling that my mind is separated from my body, and that it's my mind experiencing it. But I have no emotions, not that I become happy or sad. It's purely physical and mental. And this other one, it was like floating out of your body, going up and outside of my body, floating around freely without space and time. Lovely. So this person had a positive experience, clearly. Also interesting mystical type effects that fit broadly within the category of mystical experiences, um, including experiences of unity, transcendence of time and space, experience of infinity, of connection, of becoming part of a greater whole. Some had religious experiences as well. The bottom patient was a person who was an active Catholic. She said, "I never had such a concrete conception of heaven before. It was always something abstract. I encountered billions of souls floating around freely, not as human beings, but as spirits, kind of like birds that all flew past each other. It really gave me a serene peace." And this other person who was completely non-religious, said, "I can't describe it very well, but you realize where you are. I am the universe, or I am being. You step outside of your own little personhood. You get a kind of broader perspective on what you are and what others are." This feeling of unity was very strong. So these are, for the most part, um, these types of experiences were experienced as positive, as beautiful. And you have to remember the context in which people have these experiences is really in a very bare bones university hospital. Our Department of Psychiatry, we're building a new one, but it's really not very appealing. And interestingly, if you compare the different categories, they overlap to a certain degree. And right in the middle, I don't know if I can. Well, should not have done that. No, there's no pointer in there. So in the middle, there's an area where all these three categories overlap: the proprioceptive effects, the detachment, and the mystical kinds of experiences. And people often report experiences of kind of openness or stillness or kind of a sense of peace and calm. And I think there is potentially something interesting therapeutic that is happening there. So what people describe, this is where I think the most direct effects on people's depression or experiences of suicidality happen. It's they experience they describe it as like immediately their suicidal thoughts are gone. It's the negativity is just has just disappeared. And they feel an increased openness, a sense of stillness, a sense of calm, of possibility, and there's room for emotions there. Um, so this person describes it as the head is empty, and it's just so special after 5 years of being inside your head, where it's all very nasty, that suddenly these thoughts and feelings disappear. It's bizarre, but very pleasant. And of course, they do return, but during the buzz or the high, they were gone. And this openness, there's like a window of opportunity there, I think, and this is illustrated nicely by the first patient who said, "I also noticed that because I get less depressed, the sadness comes up more. Because of that, I think I'm also more receptive to psychotherapy." So there's this kind of plasticity, this flexibility that opens up after these experiences of interruption of negativity. Um, yes. And so I'm a visual person, but I'm not very skilled. So I try to envision what this might look like. So imagine somebody who has a very contracted mind space that is filled with negative thoughts, with ruminations, with suicidal thoughts, which makes it hard to connect to other people, to their own emotions, to their self, to the outside world. And what this interruption of negativity does, it kind of expands their mind space like that. So both the negative thoughts that fill that contracted mind space, they become less important. They become smaller in the grand scheme of things, and it enables them to feel connected to their own emotions, but also connected to others, connected to the outside world. So all the disconnection and the isolation that people experience in their depressed state, all of a sudden there's a window of opportunity where they become more connected. But it's temporary, it's transient, and it fades away. And I think this is an important lesson for us as well. I think this is something that if you want to maximize the potential of ketamine here, you should capitalize on this temporarily expanded uh, time of openness. And I think this is actually one of the themes that emerged most throughout my interviews. Those of negative experiences. So many people had experiences of fear and of anxiety, of chaos, confusion, especially because experiences for many people were really overwhelming. Um, and I will try to read. Um, I'll try to read the bottom one first, and maybe the myself will have gotten out of the way in the top one. I find it very difficult to describe this, but I was completely out of this world, really completely gone. I don't perceive the outside world either. There I am, or I am not. I don't perceive the outside world either. I'm not able to move. I'm not here on Earth. I could no longer think, oh, this is just a side effect of ketamine. I was totally lost in affinity. This resonates with me. Um, and this person had almost exclusively terrifying experiences. This I think after I had interviewed this person, thank you. I shared this with my colleagues, and everybody woke up to the fact that we are under treating this patient. We're not providing the quality of care that we ought to. We started improving our treatment protocols. She said, sometimes I just have this horror experience. I can't get out, and I don't know how long it will last because time just doesn't exist. And at first I think, shit, did I take too much? And then it just goes wrong. It all goes so fast, and at a certain point I can't think anymore. I'm just in that darkness and I can't leave, and it takes forever. Such an unpleasant experience. And this was a person who also at some point felt physically sick. She told me, and this was a shocking thing to me. I've worked in psychedelic care services, and the fundamental elements of caring are you're there for a person if they're sick or if they soil themselves. You care for them, you provide for them. This person had vomited, and she had lived close to the hospital, so She had thrown up and she had to leave the hospital after the session was over in her clothes by herself back to her home. And yeah, I thought, okay, this is something that it's completely unethical to do. Luckily, most people agreed and nobody understood, because I don't want to disparage the nurses, the people, the staff working at the hospital, but the fact that this can occur and this can occur with people with vulnerable people in altered states of consciousness is a little bit shocking. And central um, to this, to these anxious experiences, these fearful experiences, is the fact that many people had a lot of difficulty letting go of control. And if there's anything that a high or an intense ketamine experience does, it is makes you kind of lose control in different ways. And it's something that many people struggle with. Obviously, there's a large degree of rigidity in their thinking there. Um, and well, this person says, letting go is just something I'm very bad at. And it's something that I must do well. That doesn't work at all. Um, it wasn't formulated as an obligation to relax more, but in my head it was. Um, Somebody else said, I found it very unpleasant to no longer be present in my body and to give up control. That's something that I don't like anyway, but it happened very violently during the ketamine session. And also, the more frenetically you try not to think about something negative, the more it actually comes to the foreground. So people start resisting these unexpected, intense, overwhelming experiences, which they cannot do, which creates resistance, which creates fear, which reinforces the whole process. So they reinforce each other. This trying to maintain control and not give in to the experience, which creates further anxiety, and this transports into subsequent sessions. So that they enter the next session with a much more anxious mind state already. Um, yes, okay, yeah, that's exactly what I wanted to say. So earlier I became very anxious, and then you lose control, and I had some unjustified fears as a result of these early anxious experiences. And every time I take ketamine, I still experience that resistance to it. It's hard, and I'm still looking for a way to deal with it. It's getting better, but that one anxious experience had a big impact. And something else that many people struggled with or felt lacking was support, and both professional support and informal support. So because it's the way it was set up is a relatively minimal intervention. People go in, they do some questionnaires, they get their blood pressure taken, they go into a room, they get a little tiny cup of ketamine, they drink it, and they lie down and they're left alone basically. And then half an hour later, the nurse will return to do blood pressure checks and then check if somebody is okay. But that's basically the extent of the sport that people have. And if they have these frightening early experiences, um, and there's no one there to reassure them or to take care of them, well, this, as you can imagine, further increases the anxiety. Um, and this person said the few times I managed to surf the waves were when my husband was there. Having somebody I could trust completely sit next to me ensured that I could also think of it a little bit more like an adventure instead of just resisting. Um, And this other person said nurses did listen, but more out of politeness than that they had really had the time, because then they had to get on with something else. I can understand that, but I think that if you have the space to talk about it, the experience stays with you longer because it ebbs away quickly. And this is, I think, fundamental. Having somebody there sitting next to you, who's present, who has the time, who has the empathy, then understanding of what you might be going through, and is there to help you move through it, is really important. As is a private environment with few outside inputs that is private and comfortable. And this is another example of somebody who was in the inpatient clinic, said, you just hear what somebody comes in, even when you're in the middle of a session. So she later told the nurses, no knocking when you come in, and put a sign on the door for the cleaner. Because with her, that happened. She'd been in the middle of a session. The cleaning person had come in to clean the room. She was in the middle of a session. Yeah, so session interrupted, out of the experience. And this is somebody who some people, I won't go into much detail, but some of the people who had progressed to taking ketamine at home, they developed their own strategies to improve their environment. So this is not something that we help them with, or that my colleagues help them with, because they also had no guidelines really to how to ensure that people can best do it at home. But people developed over time their own strategies, including sometimes ways to minimize the effects. So they would take it, they would have a big meal first and then take the ketamine. So just so they could avoid any of the psychoactive effects, or taking it before going to bed, or just making sure that they're in a very nice room that they feel comfortable and safe. So based on this, we developed a list of minimal recommendations, and these are my final slides. You don't need to copy it. You can find the article in Frontiers of Psychiatry where we published the list. These are all relatively basic information for people who have an understanding of the importance of set and setting in psychedelics. But within ketamine treatment, the majority of which is done, I think, not in the context of psychotherapy, but purely as infusions for the treatment of depression. They don't take many of these things into account. And there was a recent publication in the American Journal of Psychiatry, co-authored by many of the principal investigators who've done a lot of the ketamine studies, providing recommendations. And there are multiple recommendations, but if you look at the recommendations here, there is almost nothing about the physical context, the kind of support that you need to offer to patients being treated with ketamine. They're all very biologically oriented, and have very little attention for set and setting, which I think is an issue. So finally, my last slide. So unexpected intense experiences do occur, even at low doses. So it's important to be aware of this, and that fearful experiences impact the sessions that come after. So it's important to avoid that as much as possible. Patients struggle with loss of control, and resisting the effects is often counterproductive. So physical presence, a warm supporting environment, emotional support by peers, by parents, friends, partners is very important, as is feeling heard and being taken seriously. And most importantly, I think we only found out about this by talking to patients and by explicitly giving them the room to talk about these experiences. And my colleagues were a little surprised that I had found out so much more, but it's only after really taking the time and sitting down with them and giving them the space to talk about this is how we found out about these. So we've since adapted this. We've created a module to train clinical staff at all the sites that we're doing ketamine treatment with. We've just started a big RCT comparing ECT to S-ketamine treatment. So we have a training module. We have improved our education materials. I think it's not where it could be, but it's much better than where it was. And I'll leave you with this final quote, and then I'll wrap up. And I've exactly talked for 30 minutes. By Bruce Cameron: "Not everything that can be counted counts, and not everything that counts can be counted." Thank you very much.